for payment outside of a certain window. But we're looking to see if that's something that we may be able to live with, to again assure that we get to April 1 with minimum disruption in client access to medications. So a lot of wheels are still churning, things are up in the air, but we are looking at every potential funding source to get us to April 1. I wish I could say conclusively that all of these are resounding affirmative, that we will have all these flexibilities that we're requesting, but I simply don't know that at this time. But we are continuing to work very hard on that. All right, looking at the current wait list, we now have officially 1,975 persons on the ADAP wait list in Florida as of last Friday. 400 clients were transitioned on the wait list late last week, because when HRSA basically gave us their decision that you had to use $3 million to take waitlist persons, we have basically 9 months now, I think it's through July 2011, that these special dollars are available for. And we can't request carryover, and we can only use them to provide drugs to waitlist clients. So our calculations show that it would support a little over 400 people for that time frame. So that initiative is underway now to contact the impacted clients and get them enrolled in the program if they still need services. And there's basically a 21-day window which has been set up to achieve the enrollment. And you may remember that the medical team worked very hard on coming up with a medical-based waitlist categorization for each client as they came on the waitlist. And that was done with the idea that first come, first serve may not be the best way or the most appropriate way to take people off the wait list. Well, HRSA basically mandated that we had to take people off the wait list on a first come, first serve basis. And they were looking at the window of June 1st through July 8th. So all the work that the medical team and others did in coming up with this medical categorization process, really we cannot bring that into play for this process because HRSA prescribed basically what we have to do. And it is a first come, first serve process. But the medical categorization remains, and as clients come on the wait list, that is still done, because after this process, I would expect that the states would have some flexibility in how they deal with bringing people on the program from the wait list. All right, and some of you may wonder, you've got a lot of things going on. You're talking about bringing people off the wait list into the program. You're talking about changing your financial eligibility criteria from 400 to 300%. Is there a potential for some people to be brought onto the program, say this week or next, only to be removed from the program in a month? And there were 12 people of that 400 and some odd people on the wait list that were impacted by this movement from the wait list to the program. There were 12 people who had incomes in that 300 to 400% range. And the decision was made for the Bureau staff to contact those clients individually and talk about what all this means and what is the best decision that needs to be made to make sure that their needs are put first. And there's no requirement for them to come to ADAP if they talk it through and say, well, it doesn't make much sense for me to get one round of medications, and then next month I'll come back and I'm not eligible, and then I have to start this whole process for patient assistance program application again. So that's the discussion that we're having with the patients and just making sure they're aware, not telling them what to do, but giving them information to make the correct choice for them. And the patient assistance programs are only being notified as people are enrolled into the program, or if they say they no longer need ADAP. If they're in a patient assistance program, we are required to have some contact with them. But if a person is not contacted, if they could not be found for whatever reason, there's no contact with the patient assistance program. So there's nothing that the Bureau would do to jeopardize whatever arrangements they have to get their medications now. We're only dialoguing with the patient assistance programs basically to confirm that people are now in the ADAP program and no longer needing their services. So that's sort of how we plan to talk with the patient assistance programs as people come off the wait list and into the program. Some other big developments in January, of course, are that ADAP expenditures will count towards meeting the troop requirement for Medicare Part D. And this is a really big deal. In the past, people who didn't have low-income subsidy or partial low-income subsidy would basically come into ADAP and we would serve them year-round. But because of this potential, we'll actually be able to transition people to catastrophic coverage, and that literally has the potential to save the program millions of dollars in 2011. So we're very pleased about that. Also, we are requiring that Medicare Part D clients actually use their initial benefit. I think it's $2,840 at the beginning of the year. In previous years, because of the concerns and lack of getting people to catastrophic coverage, we would just enroll them in ADAP initially, and they could use that benefit for other medication needs that ADAP had to sponsor. But one thing that HRSA has come back on us, and discussion after discussion, is that, you know, Ryan White needs to be the payer of last resort, and I really don't have the luxury of being able to just not require people to use that initial benefit. You know, and so HRSA has been pretty specific about that, and they're supposed to release a major policy guidance on how ADAP and Medicare Part D will work together in 2011. We've been promised this policy guidance for a couple weeks now. I haven't seen it, but as soon as it is released, we'll certainly share it broadly, and this body will have access and knowledge of that. We do know that there are over 500 people in ADAP with Part D benefits, and as I said, it literally would have the potential to save millions of dollars for the program. And once that initial benefit is utilized, ADAP patients with Part D would come back to the program, and once they hit the donut hole, basically ADAP would get them through that, and they would continue with services. So no one's going to be closed out who is in ADAP and has Part D. They would simply not use ADAP for probably a month or two, because I'm sure it doesn't take long for that initial benefit to be utilized with HIV/AIDS medication cost. We're asking that you know, if clients are able to pay for the out-of-pocket expenses, they do that. We're asking our Part D consortia, Part A programs, any other local funding source, if clients need assistance with the out-of-pocket as they utilize that $2,840 benefit, that local resources be investigated to see if they can assist the client in using that benefit. However, we have made the commitment, if nothing works, if the client cannot afford in any way the out-of-pocket expenses, if there are no local resources that can be found, ADAP remains a safety net program, and in those cases, that discussion needs to come back to ADAP, and we'll make sure that the client's needs are served and no one is just removed from the program with no way to get the medication. But we're trying to work smarter, we're trying to work more efficiently, and acknowledge that because of the ADAP changes in troop, this is a smart and judicious policy change to make at this time. Related to this, the department has started the process to procure pharmacy benefit management services, and this is a big deal. It's critical to be able to report to CMS what ADAP expenditures have been expended towards meeting troop. It will actually give us other ability to integrate and assess persons' insurance, if they have insurance, if there would be a potential for billing unique services to that insurance. This is going to be a very substantial leap in our being able to coordinate and be aware of other insurance benefits clients may have. So we are expecting an RFP to be released in the next several weeks with a target date of April 1, 2011 to actually have a PBM in effect for Florida, and it will be very impactful, we're certain. Another thing that it will allow us to do, it will allow us, as we make co-payments for clients to get their HIV medications, we will be able to seek some additional rebates based on the value of the medications that we assisted with that co-payment. And that has the potential to possibly generate some revenues for the program and just allow us to work smarter in using the more health insurance benefits that clients may have. And finally, I wanted to acknowledge that we've had several visits from HRSA during this crisis. We had a visit back in August for a fiscal analysis of our program. And Tom Hickey, some of you know Tom from other meetings and venues, came down and did that review, and overall was pretty positive for us. And along with Tom, there was supposed to be a programmatic review. We were going to have ADAP manager from Texas come in and look at our program, but there was a conflict and he couldn't come then. That visit was basically postponed to about 3 weeks ago. The week of October 18th, we had probably a 6 or 7 person team come in from HRSA and spent 2 days in Tallahassee going through our ADAP program. And then actually, I think the staff sort of broke up at that point, and all 6 of our EMAs, Part A programs were listed in Florida, and we were promised a pretty comprehensive trip report from that visit. We have not gotten it yet, but we were open for any recommendations and guidance that they wanted to give us, as in things that we could do differently to better run our program and to gain any additional efficiencies given the crisis that we're in. Although I don't have their written report, based on their exit interview, they didn't have any game changers, I would call it, per se. 2 things that they did say: they're aware that people with insufficient or poor insurance policies are able to come into ADAP. They said that we may want to investigate, even if it's a poor problem, there may be some opportunity for reimbursement for some costs related to that drug. They encouraged us to look at that and acknowledge this PBM capability we're seeking would be very important in being able to do that. Another thing that they thought that we needed to look at, again, related to PBM, pharmacy benefits management, was the issue of seeking any additional drug rebates we could based on the co-payments that we make for HIV medications. So those are things that we sort of had on our agenda anyway, but we certainly acknowledge that they're interested in that. And as soon as we get their trip report, HRSA is notoriously slow in getting that type of information out, but as soon as we get it, we will certainly share it widely around, and it will be available for public